Hi, y'all. Welcome to the AirBorne Virtual Conference, COVID-19 edition. My name is John Seegers, President of International Biomedical. We know it was disappointing to all involved to cancel the 18th annual AirBorne Conference here in Austin. We were looking forward to seeing you and hope you'll join us next year for an even bigger event. However, we also know how important it is to be able to provide educational content for you during this unprecedented time. COVID-19 has changed all of our lives, and we hope our experts can offer some insight to help you in your careers as transport professionals. I'd like to thank Dr. Holcomb, Dr. Lancaster, Dr. Meyer, and Dr. Harris for their dedicated efforts and expertise in providing this content to you. And lastly, I'd like to thank all of you for tuning in today. Without your support, we could not make this happen. So without further ado, I'd like to introduce Dr. Robert Holcomb, who will kick off our virtual event with his talk on COVID-19 on transport.
Thanks, John. I want to thank everyone from International Biomedical for putting this on. John came to me about 4 weeks ago with the idea, and it really was perfect timing. At the American Academy of Pediatrics in the section of transport medicine, we have been getting flooded with emails and phone calls from folks all across the country and even some folks outside the country asking for continued guidance on how to transport patients who are either under investigation or have tested positive for the COVID-19. We hope that today we can provide some of that additional guidance for you and help make your job that much more safe. I will say that the American Academy of Pediatrics is working on some formal guidance, which the section hopes to have out in the near future. One of the reasons for doing this is the CDC has always been a great place to go to get information and guidance for COVID-19, but unfortunately, they haven't updated the site for EMS transport since March 10th. And so we're hoping to bring some of the new information that's been learned since then. One thing I will caution folks on is that, as you know, this has been a very tumultuous time for us, and things do change almost on a daily basis. Those that receive these scattered emails that say things have changed on a daily basis at your institution can certainly appreciate where that's coming from. That being said, certainly things can change over time, and hopefully in the future we'll continue with correspondence to keep you up to date. What you're going to hear today is information that is compilation of work from the CDC, the American Academy of Pediatrics, transport experts, infectious disease experts, critical care, emergency medicine and neonatal experts, and many more. This is applicable to transport. And so we're not going to get too deep into some of the weeds regarding the actual long-term care of COVID-19. And there are certainly resources for that out there already. I do want to let you know that if any of your colleagues are unable to see this webinar because of patient care duties or they're out on a transport, this will be recorded and available on the International Biomedical website. You can, at that point in time, view it for free. The only caveat is you won't be able to get, unfortunately, CEUs at that time. So as we get started, I'd like to welcome all the teams that are participating today. I will tell you that we've had close to 1,500 people register for this webinar, and those folks have gone beyond the borders of the United States, and so we recognize and really appreciate and welcome our international colleagues as well. Okay, so let's get started here. Again, this is going to be going over the transport of the critically ill neonate and pediatric patients who has suspected or confirmed COVID-19. We have really nothing to declare financially, and we're not going to discuss any unapproved use of commercial products or devices. We will have a short segment because of demand where the International Biomedical Engineers will be discussing the product-specific materials on the Voyager ALSS. This was a big topic that we received both at the Academy and down in Austin as far as help with preparing our ALSS for the next transport after having moved a COVID-19 patient. So we'll be bringing the content as well. These are our objectives, and over the course of the lecture today, as well as the question and answer, we should be able to meet each of these 4 objectives for you all and help you get better prepared for safer transport. As we all know, the COVID-19 pandemic has impacted the United States healthcare system in an unprecedented way. We hear daily through various media, either on TV or through email or open exchange, ways that the pandemic has affected people all over the country and all over the world. We recognize the importance of providing the best medical care we want to, but by the same token, we're very cognizant of the fact that we need to reduce the risk to the transport team members. And last but not least, minimize the use of PPE, knowing that there is a potential for a shortage of supply, and in some areas already experienced. We want to balance the infection control with the transport safety. And as you all know well too well, this is quite an austere environment that you practice in, whether it be on a fixed wing aircraft or rotary aircraft or in the back of an ambulance, whether it be a 30-minute ride down the road or a 12-hour ride across an ocean. We respect what you guys go through each and every day. So what we're going to do today is we're going to have an overview of the main issues regarding transporting COVID-19. We're then going to open up with a panel discussion with an expert pediatric infectious disease, pediatric intensive care, and neonatology. We've had a tremendous response to questions that were asked before the webinar started, and we'll have those questions to ask. But we also encourage folks during the course of this presentation that I give, as well as during the Q&A, to please submit questions on the Q&A side of your Zoom, and we will look to get to those as well. Just a few housekeeping items. We may not get to all questions. With 1,500 people on the line, I don't think we'd be able to get to them all in the time period that we have allotted. Also, AirBorne is more than willing to give additional information on any and all questions that pertain to the International Biomedical Airborne Division equipment that you use for transport. We'd like to kind of shy away from any case presentations in the sense that we really can't, because of HIPAA violations, talk about individual cases that you may have experienced. So please try to keep those questions a little more on the general side. But any and all clinical questions are welcome. And with that, we'll go ahead and get started. So one of the first questions that was posed to us is, what screening process is used to identify patients at risk for COVID-19 and or those that have tested positive? And when looking at the screening process, we believe it begins first and foremost with the call that comes in. Now, different transport teams are set up differently. Some have an access center. Some it goes directly to their dispatch, and in others it goes directly to a member of the transport team. That's the optimal time to begin the screening process. Initial questions may revolve around common symptoms, which, as we know, are changing every day. Just this morning, there was a report of the inflammatory disease that we're seeing in children, almost like a Kawasaki type disease, and that should definitely be looked at as possible included in symptoms as well. Also looking at recent exposures within the last 2 weeks. South Korea showed very poignantly that following and tracing back exposures 2 weeks back made a difference as far as limiting exposures. These questions pertain not only to the infant or child, but also to the mother, father, and any close contacts that may have come in contact with the patient. This information, along with the clinical state and results of any COVID-19 screening tests, must be shared with the transport team during the pre-transport huddle. That's not to say that you shouldn't go out prepared for the worst, like we always say, but by the same token, if this information is known, we need to make sure that the transport team knows this before they depart. And then, upon arriving at the referral center, a secondary screen by the transport team should be performed. I can't tell you the number of stories I've heard where folks have passed initial screenings at hospitals and other areas, only to arrive at the unit with the answer to a question that puts them at high risk for COVID-19, and they end up testing positive for COVID-19. So the more times that we ask and the more times that we screen, the safer we're going to put everybody in the end. So having the transport team continue that when they arrive is not redundant. It actually serves a purpose. So what precautions can we take to limit exposure at a referring facility? This can be very difficult, in part because a lot of facilities have gone down to just one or two entrances, given the fact that they can then screen anybody who comes and goes in and out of the hospital more effectively that way. That being the case, a lot of us are referred in through an emergency room, which was, as we know, can be a very, very busy and high traffic area, with a lot of potential for exposure. Calling ahead to see if there's a way that we can get or avoid the emergency department and other high traffic areas for possible arrival and departures is very advised. Security escorts for the arriving transport team can help also, and they can get us where we need to be in regards to from the entrance to the unit as quickly and as avoid all possible high traffic areas as possible. Transport teams should be wearing surgical masks, eye protection, such as goggles or face shields, and gloves at a minimum prior to entering the referring facility. Let's talk a little bit more about that. So is there a minimum level of PPE teams should employ with any transport during this pandemic? Folks, this is a topic that met with a lot of discussion. And I think that we've seen already, for instance, in the moms who are pregnant and getting ready to deliver, a substantial amount of them can be asymptomatic. So when you go back to your screening tool and you ask the questions that need to be asked, you may find that some may, for lack of a better word, slip through the cracks. We want to protect you as much as possible. Now, we also recognize the fact that we can't necessarily send everybody and their kid sister out in PAPR devices. And so that being the case, we want to protect you, but also be smart. And so what has been the conclusion is that a surgical mask with eye protection, such as goggles or face shield, and gloves at a minimum when you're going out on any transport as you prepare to enter the clinical arena. And so it doesn't matter whether the patient is positive or negative, this is your minimum protection that you should be wearing now on every transport. Now, personal eyeglasses has come up, and they do not count as a substitute for eye protection. So all those folks that have glasses, they may want to prescribe to a face shield or the larger goggles that appear in the inset on this slide to go over their glasses. But those alone do not count as proper eye protection. What is the appropriate PPE for the transport team if the neonatal child is a PUI or a COVID-19 patient? So everyone, including the ambulance driver, the rotary, the fixed wing personnel, the EMTs, the paramedics, both in front and in back, everyone should be wearing PPE consisting of an N95 mask or a powered air purifying respirator, PAPRs. They should be wearing eye protection, they should be wearing an impermeable ground, and they should be wearing gloves. Let me say that again, everyone, including the EME, the EMT that's in the back with you or up front in the ambulance, the paramedic, the nurses, the doctors, everyone should be wearing PPE. Now, this additional PPE should be donned prior to entry into the patient care area. Also, if at any point in time you need to be performing aerosolizing procedure, an N95 with proper eye protection or PAPRs is required for any team member who's performing those aerosolizing procedures. Let's talk a little bit more about that. So what do we talk about as far as aerosolizing procedures? These are some of the examples that are out there, such as performing bag mask ventilation, such as intubation, such as suctioning, oxygen flow at a flow rate greater than 2 liters per minute, continuous positive airway pressure, and or positive pressure ventilation, cough assist or cough inducing procedures, or during medication administration via nebulization. This is not all inclusive, but it gives you a nice broad idea of what we're talking about with aerosolizing procedures. In addition, we recommend the use of an approved bacterial, viral, HME, or HEPA filter. There's various ones out on the market, and when you look at the manufacturer specs, you want to make sure that it carries at the minimum the same specs as an N95 mask, although most of them carry greater than 99% filtration. Now, I will tell you, when folks have used these devices for bagging patients, they have noticed that during the humidification, return, and exhalation, that moisture getting into the HEPA filter has caused more resistance to flow and therefore created higher pressures or inspiratory pressures required to properly ventilate the patient. Keep in mind your bag is located on one side of the HEPA filter and the manometer on the other side, so you'll know exactly what you're giving to the patient. At some point in time, it may come that you have to switch out to another HEPA filter. Another place that we recommend using the HEPA filter is on the transport ventilator, and this should be placed at the expiratory side to limit exposure to the team. I'll show a slide here in just a second as far as what we're talking about with the Phasotron. Another thing we recommend is that you try and keep as many of your bag sets outside the immediate clinical area as possible. Have a, quote, clean area team member stay out there, and they can then pass equipment and supplies as necessary. Last but not least, aerosolized generating procedures should try and be avoided during transport unless absolutely necessary for patient care. Obviously, that doesn't mean holding off on an intubation, but if a nebulizer is not quite necessary and can wait until you get to the receiving facility, then that risk-benefit ratio should be weighed. This is an example right here as far as the HME filter inline, and here's the mask, and here's the bag. Here, you'll notice the Phasotron. We've got the HME inline, the Phasotron. Now, the one thing you may notice is that this may alter the pressures that you get on the ventilator. So be very leery of watching closely throughout the transport whether those pressures change, because they might provide additional end expiratory pressure or mean airway pressure more so than what you wanted. And then last but not least, you'll see it here at the expiratory side of the circuit that's hooked up to a cross vent. What precautions should be taken during attendance at delivery by the transport team for neonatal patients? As many are aware, the first part of April, the section on neonatal perinatal medicine, together with the Committee on Infectious Disease and other sections, got together with the American Academy of Pediatrics and came out with formal guidance for attendance at deliveries. In modeling that, we're looking to provide the same protection to our transport teams that are out there in the field. So appropriate PPE should be worn to include gown and gloves with either an N95 mask and eye protection or a PAPR. If at all possible, the mother should wear a surgical mask. Obviously, there's limitations during that period of time, especially as they're going through labor. If at all possible, you should place the resuscitation table greater than 6 feet from the mother. If intubation of the mother is necessary for general anesthesia, if at all possible, the transport team members should leave the operating room. Again, an approved bacterial viral HEPA filter should be put in line with the bag. And then once the child is in the transport isolate, every effort should be made to keep the portals closed and access limited to just times of emergencies. Again, looking at patients who are born to mothers who are suspected or confirmed COVID-19. Keep in mind the previous slide was just for all deliveries. When we have one that actually the mother is suspected or confirmed COVID-19, at that point in time, those neonates should be considered as positive for COVID-19 for the duration of the transport. We do not know right now completely how coronavirus will infect a newborn. There have been case reports out there in various places, including the UK and China, but upon more epidemiologic evidence, it appears the child was actually exposed after birth. There have been some small case series that have looked at IgM levels, as well as looking more in depth at babies after delivery to COVID positive mothers. And there's yet to be conclusive evidence that is passed on through vertical transmission. That being the case, we still do not know. And for the purposes of this transport, where you're out there taking care of these patients, treat them all as presumptively positive. So appropriate PPE should be worn. And then prior to arriving at the receiving facility, alert should be given to that facility that you are bringing a patient who is presumptively positive for COVID-19. And again, I steer you towards the initial guidance that was dated April 2nd, that was done by the American Academy of Pediatrics, a Committee on Fetus and Newborn section on neonatal pediatric medicine, and Committee on Infectious Disease. What special procedures should be taken for air transports involving the use of either flight line or helipad? As you all know, the flight line or the helipad can be a very dangerous area. And we are very, very staunch on our safety protocols that we follow when we go out to the helicopter or go out to the fixed wing. One thing, a very important stress, is that you should not be carrying anything on your body that is loose and can lift off your body during a hot load. With that being said, prior to departure from the building onto the helipad or flight line, teams should consider removing the PPE gown. This is not because the wind will blow the gown up and spread the coronavirus all over the place. No, that's not the case. This is because, as we all know, the gown can be sucked up into a turbine or into a prop, and then your transport will be quickly ended. This would also apply prior to offloading the patient. Again, we're trying to create a balance of infection control with flight line safety. Now, this is especially important during hot loads, but we caution teams who normally hot load to consider shutting down prior to loading. At a minimum, an approved surgical level 3 mask or N95 mask must be worn by all non-clinical team members, such as the pilot, the co-pilot, the safety officer if they have no clinical duties, in the cabin for all PUI and patients with confirmed COVID-19 during the flight. And I really stress for folks to reach out to your vendors, the folks that operate your fixed wing, your helicopter, your ambulances, and really talk these things over with them so that everybody's on the same page. How can families, caregivers, and children be supported during transport? As we all know, this is a very scary time for all of us, adults included. You can imagine what the children are going through, and especially if they're the patient that we're concerned has COVID-19 or has some other significant problem going on from a medical standpoint that's requiring a critical care transport team such as yourselves. We need to be very, very cognizant of the fact that these kids may be frightened and unable to communicate. And if any of them have any form of neurodevelopmental challenges, it can be even twice as worse for them. So a plan to address the unique psychological stress and challenges a symptomatic child and family members experience should be developed by each of your transport teams. When transporting a child with an impairment in communication, the transport team should be aware of how the child expresses pain or what he or she needs. Very important that we understand how the child's going to communicate with us. The risks and benefits of allowing a caregiver who does not have COVID-19 or is not a PUI to join us on a pediatric transport should be considered. In some cases, with a very severely affected child that has difficulty communicating, you may very well want to have that parent on board with you to help you understand what that child's going through so you can provide the necessary care. However, a caregiver should be discouraged for traveling with a neonatal patient. I think what you see there is a balance of risk-benefit. Masks should not be used for patients under the age of 2 years. For patients over the age of 2 years, use of a mask on a PUI or patient with confirmed COVID-19 can seem very intimidating, but is still very much encouraged. Do the best you can. Certainly, if you have a provider with them who's not part of your team or a family member, having them wear the mask and them seeing them wear the mask might help, because they will be required to wear a mask. Before departing the referring hospital, advise the family of any restricted visitor policies at the receiving institution to prevent any misunderstanding. Again, a lot of hospital systems have shut down the hospitals to no visitors or one visitor. And this can be very traumatic on a family that is sending their child with you to the hospital and they're not able to go with you. We need to let them understand ahead of time what is allowed and not allowed during this very precarious time. And this will be up to you and your hospital administration and what your receiving hospitals allow and don't allow. But we always find it best if you let them know ahead of time what to expect. How should the ambulance, helicopter, and fixed-wing aircraft be cleaned? Each transport team, as I said, must work in partnership with their vendors to ensure the safety and well-being of all. Each vendor should have specific cleaning procedures that must be performed after each transport of a PUI or confirmed COVID-19 child. Full PPE should be worn during each cleaning procedure, and any surface that potentially becomes contaminated during the transport should be wiped clean with an EPA-approved disinfectant. Right there, I have for you the website that keeps up to date on what is an approved disinfectant that can adequately kill the COVID virus. You can look at that and copy it down today, or you can go onto International Biomedical's website and view this webinar again. Certainly going into Google, you should be able to find it as well. So, as I mentioned before, we have received a number of emails, phone calls, inquiries into how to clean the transport incubator after transporting a PUI or infant with a COVID-19. Because our recommendation is to follow the manufacturer's instruction, we're going to go ahead at this point in time and turn this over to Joe, one of the engineers for International Biomedical.
Thanks, Dr. Holcomb. Some of the most common questions over the last few months have been, how do I clean the transport incubator and what parts should I clean? The next few slides outline the recommended steps you can take to disassemble the transport incubator to its lowest level for cleaning. This process does not require tools and can be done by any clinical or hospital staff. First, ensure the unit is turned off and allowed to cool down. Then, locate each of the 4 chamber latches and extend each latch pin away from the chamber. Carefully remove the chamber and separate the inner and outer pieces on a stable surface. Now that the entire patient compartment is exposed, you can remove the patient mattress and chamber sealing gasket. Next, remove the intubation tray by toggling the 2 black swell latches in the up position. Pull up on the tray and then slide the tray a few inches towards the direction of travel. This will allow you to disengage the 2 guide wheels from their tracks and remove the intubation tray completely. Next slide, please. Now locate the 4 swell latches of the patient tray. There's 1 in each corner. Toggle the swell latches in the up position and then pull up on the patient tray to completely remove. Before cleaning, separate the patient tray from the aluminum deflector panel by unthreading the fasteners of each swell latch. These fasteners are designed to be manipulated by hand, so no tools are necessary. Finally, remove the impeller shroud by toggling the 2 black swell latches in the up position and then pull up on the impeller shroud. Once exposed, pull the impeller off the motor shaft and set aside for cleaning. Now that the transport incubator is fully disassembled to its lowest level, thoroughly clean all surfaces and components with approved cleaning solutions detailed in the operator's manual or per your hospital's infectious control procedures. After the use of cleaning solutions, wipe down all surfaces and components with a damp cloth to remove any remaining residue. When all the components are clean and dry, reverse the steps to reassemble the transport incubator. This cleaning guide and the operator's manual can be found on our website at int-bio.com. Thanks to Dr. Holcomb for the opportunity to share the recommended method to disassemble and clean the transport incubator.
So folks, across the US, in cities everywhere, New York, Detroit, New Orleans, and Seattle, from the deep south to the northwest, from the sandy beaches in California to the shores along the northeast, in the mountains or on the plains, Americans are confronting COVID-19. To the brave men and women on the front lines, we say, thank you for being there. Thank you for taking care of our children. Thank you for putting your life on the line. The austere environment of transport medicine just got quite a bit more complex, quite a bit riskier, and quite a bit more challenging. We will overcome. As a team connected by one cause, we will come together stronger than ever before. Use your resources, Call on your fellow transport professionals across this country. We are stronger as one. For those from our international brotherhood, there are no walls, no borders, nor impediment of any kind. We are there for you and you for us. God bless you all in the air or on the ground. So at this point in time, folks, we're going to open up our panel discussion. We've already had a number of questions that have come across. We certainly will try and get to them as much as we can. As far as our panelists are concerned, we have Dr. Joanne Harris. She is a pediatric infectious disease specialist with almost 40 years of infectious disease background. She was prominent at the University of Kansas, and she's over here now at Overland Park with us. Dr. Michael Meyer, Mike, he's a medical director over at Pediatric Intensive Care Unit in Children's Hospital, Wisconsin, and he was in the Air Force with me for quite a long time. Mike was actually on one of the teams first to go into Afghanistan when that conflict started. And Dr. Tom Lancaster, who is our medical director here at Overland Park Regional Medical Center and trained at Washington U. And he also heads up our neurocritical care unit. So folks, at this point in time, I'm gonna go ahead and turn this back over to our host. Give me a second here. Okay, there we go. Okay, folks, so we'll get started here. The first question I have is for Dr. Harris. Dr. Harris, how long does a baby have to stay in isolation if the mother is positive?
You know, that's an excellent question. And it's one we deal with on a daily basis because it really depends on the individual situation. It depends on how long you've known that the mother is positive. If the mother has been out of isolation, and there's two ways to determine that. There's been two options. One is a symptom time-based option. The other is a testing-based option. The symptom time-based option is if the mother's was tested, it's 10 days from the test, being 72 hours afebrile with no antipyretics, and resolution of symptoms, which can be tricky, right? So that's the symptom-based strategy. With the testing-based strategy, they use the COVID-19 PCR testing, and after 7 days and afebrile, as we spoke before, 2 tests 24 hours apart need to be negative. The problem with the testing-based strategy is that a negative test is the test at that moment. And so a negative test could turn positive in 2 days, for example. The other problem with repeat testing is if the mother was COVID test positive, there are a lot of patients that keep continuing to be positive with their subsequent testing, and you don't know if they're infectious or not. So it becomes really complicated. If you're transporting a 30-day-old, for example, child, and you knew that the mother was positive at delivery, that could appear to be enough time for both the mom and baby to have come out of isolation. And that's different than if you're transporting a baby that's 1 or 2 days old. Older children, I have to emphasize what Dr. Holcomb said, in a child's environment, the screening has to encompass the household and all that the child has been exposed to. So I think you're going to need to really work with your referring facility and get clarity from them at what stage this child is at, and also what stage or what the screening of the household has been. So it's not an easy yes or no answer, unfortunately. It's going to be a team effort between the referring hospital, you all in transport, and the condition of the child and parent if they're transporting with you. I agree with Rob that any adult that is transporting with you should wear a mask for your protection. And my personal view is that we couldn't do any of this without you, and you need to take as much personal protection as you feel comfortable with. And so that's a very long answer to a common question.
Oh, that's okay. That's okay. The next question is for Dr. Meyer. So Mike, pediatric critical care has got all kinds of different patients that we transport, and some a lot more complex than others. We talked a little bit about the aerosolizing procedures and trying to avoid aerosolizing procedures. But what about in the complexity of a child that has a tracheostomy? Do you have any words of wisdom for us in that sense?
Afternoon, everybody. I think that's a great question, and unfortunately, it is something that does confront us. The child with the tracheostomy, whether it's a trach alone or a trach vent patient, is the highest aerosolizing potential patient that we could take care of. When all of the information about COVID started flowing, these aerosolizing patients were a significant concern. The unfortunate part is many of the things that we thought were true at the beginning of this, we've had to modify based on what the adult experience has been and what we presume the pediatric experience is going to be with these patients, where we haven't immediately intubated just because of low SATs. It's been more based on distress and things like that. But I think common sense dictates several things. First and foremost is to try to isolate that patient as much as possible, which means minimum crew in order to take care of that. And the crew, first and foremost, has to be protected. Whether or not you choose to cover the patient's mouth or tracheostomy with a mask, I think there's great debate. One of the things that we do consistently, though, is that we keep an HME on the patient. And if there's any concern about the respiratory status, is that we do connect the patient to a ventilator, even if it is for just CPAP and pressure support, in order to minimize the potential for secretion spread. Following that, it's then really important for a terminal clean of the ambulance or of the helicopter or plane after you've done that transport, which may cause some delay in your turnaround time. And it has to be recognized that there's going to be delays and different metrics that we need to follow as a transport team for the overall safety, both for the patient you're transporting, your team, and then the next patient that you're transporting.
Thank you, Dr. Meyer. That was much appreciated. Dr. Lancaster, this was a very good question that was brought in before the webinar. It says, the changing times certainly make things interesting. We have been very busy with COVID transports. Our team has done over 700 so far. I would like to hear more about how people are handling the challenge of communications consults in the back of the ambulance, as well as staff burnout.
Thanks, Rob, and thanks to International Biomed and getting this off the ground today. The telemedicine piece, I think, is essential. I think any opportunity to tap into some type of telemedicine device, whether it's a formal program like what we use, or maybe even as simple as FaceTime during these unprecedented times. I think having access to your specialist or having access to the family, it goes both ways. I would highly recommend thinking about utilizing and leveraging this technology to augment our communication. I appreciate what Rob said earlier about probably limiting the family attending the transport. Some some teams will routinely bring parents. I would discourage that. But one way you can still keep connected with the family is potentially utilizing a telemedicine device. And it can be as simple as an iPad, it can be as simple as an iPhone, or an Android, of course, or a tablet. But utilizing this technology in this current era, we currently, and we've had this in place even before COVID, but we try to utilize this technology in talking with our families, especially in this time where access to their baby has been restricted and limiting visitors at the bedside. But in the setting of transport, I would think about utilizing telemedicine.
No, thank you, Dr. Lancaster. That's very true, Tom. I think telemedicine is really helping us quite a bit. And thank God that federal regulations now are recognizing the value of telemedicine and appropriately compensating for it. Question though, also, so as far as helping the team from that standpoint, that's awesome. What do you think about as far as staff burnout, especially with the fear of COVID-19? I mean, we've seen folks where they've had to stay in a camper in the parking lot of the hospital because of the fact that they can't go back to work at home because they've been exposed.
I thank you for reminding me of that part of the question. I would encourage an open dialogue between your staff and your administration about how people are doing. This is a very sensitive and very difficult time, and I think we need to recognize when people are feeling down, depressed, anxious, and maybe don't feel like they have a voice. And I think we as a leadership need to reach out and check in and have deliberate conversations and allow the opportunity for somebody to tap out if they're feeling overwhelmed. The other is strongly consider allowing people who are feeling uncomfortable with their level of protection to speak up and potentially have access to that PPE that is so essential to keep us safe. That's one thing I've encouraged among our NICU staff is if you personally feel uncomfortable about your specific situation, if you're older than 60 years of age, you have diabetes, you have asthma, that you feel particularly vulnerable, speak up. And I think it should not be punitive. And that's why I think the administration needs to take the forward step or the leadership in reaching out to their staff and ensuring that they feel safe. And having, I think, hard written guidelines and adhering those guidelines is also essential, that people have a firm understanding what their expectations are to keep themselves safe.
So true, so true. You know, and in transport, we talk so much about fatigue monitoring tools. We talk about the I'm Safe tool. And I think folks think, well, we're in a pandemic, that goes to the wayside. Just the opposite. It becomes even more necessary for providing safety for everyone involved. Thank you, Tom. There was a question that was asked about a team that carries a filter that filters 99.9% of the bacterial viruses. And it was asked, the question was, it doesn't say HEP on it, but is this still appropriate? Yes, those filters that say specifically that they filter 99.99% of bacteria and viruses, and a lot of them are used as either HME or HEPA filters. Those are acceptable. Dr. Harris, I have a question for you. Neither our traditional transport isolate nor our giraffe omni beds that we transport in have HEPA filters on them, or the option to add a HEPA filter to the isolate. The concern is both pulling potentially contaminated air into the isolate and exposing the infant in mom's room prior to departing for a positive mom, or blowing out contaminated air and exposing the environment if the infant was positive. Any thoughts? Dr. Harris, I think you're on mute. There we go.
There. I think we have to use the equipment we have. We need to then take advantage of the PPE that you are wearing. That's the point of the PPE. The isolate is considered quote unquote isolation, but one of the recommendations that you heard in Dr. Holcomb's talk is to keep the portals closed unless it's an emergency, because of what you just talked about. Definitely keep those portals closed, but also realize that you have appropriate PPE on, so that will be your protection. And that's what I said before and what Dr. Lancaster has said, to make sure that you have the right PPE on for the situation and for your own personal comfort due to your own health.
All right, thank you, Dr. Harris. Dr. Meyer, we have a question in regards to, is anyone using cappers instead of PAPers? And I fill this over to you because we use the PAPers device. Which device do you guys use?
So actually, based on if you're doing transport or if you're doing inpatient care, we do have a difference. Our transport team is using N95s with face shields when they go out for patients. When you come into the inpatient side of the house, for our PUI and our COVID positive patients, we use cappers.
Yeah, I will say on our transport, we have a problem with some of the folks who don't pass the N95 fit test. I'm actually one of them, having had a broken nose back in high school. And so I end up having to use a PAPers device. With your team members who have problems, or if they have problems with an N95 fit, do you have one recommendation over another in regards for transport?
So organizationally, we go to capper. That's been the decision of the organization. And I think people need to refer to what their organizational policy is when they move into it. There's no functional difference between a capper and a PAPper when it comes down to it, because these are the institutional policies, and as they've reviewed what their supply chains look like as things move forward. And I think that's something that we do have to pay close attention to, is where the supply chains are broken as you go through from a PPE standpoint, because the PPE supply is truly the limiting step as you look into how do we continue to do our jobs, because putting ourselves at risk shouldn't be part of our choices as we move forward with this.
Thank you. Dr. Lancaster, Amy, can you scroll up? Dr. Lancaster, there was you had mentioned something in regards to family members and accompanying them. What about as far as testing the family member, if you have enough time ahead of time? Obviously, this would be the test that would have a turnaround of more like an hour or two, as opposed to the tests that have a week or two. What do you think as far as requiring testing of parents who are going to accompany the family or accompany the patient?
Thanks, Rob. I would consider that mother, father, loved one a PUI. And the reason is because that parent is likely the most primary caregiver of the child who is, and we're assuming it's a positive or a PUI. Now this, it's like, what, 6 degrees of Kevin Bacon? How do you decide at what point, what derivation do you stop considering somebody a PUI? But I think for the purpose of transport, anybody that's been in an immediate contact or more intimate contact, so household contact, I would consider a PUI. As far as testing, although that would be reassuring, I would still take full precautions with that particular individual. So a mask, gown, gloves, just to reduce your chance of exposure. To answer it directly, though, the question is whether or not it could be helpful. I think if there's opportunity to test a person of interest, person under investigation, I would go ahead and recommend testing, but I don't know that I would delay moving that child. I would purely decide that based on the medical needs of that patient. I would not let delay and transfer awaiting specifically a test for the family member.
And I think that tails into as well what we talked about earlier during the presentation. If you think the family member is a PUI or comes back COVID-19, they should not be the one accompanying the child on the transport. The risk is just too high.
I agree.
Dr. Harris, you know, one of the things that we do as transport folks is when we get the child ready to go, we want to show the parents, you know, what everything is involved in the transport. In the case of the neonate, they're in the isolette, the ALSS, and we let the parents see the baby before the baby actually leaves. And with the mom, a lot of times she's in her room. As you can imagine, this can be very difficult if mom's under a droplet or aerosolized isolation because of COVID-19 or PUI. Do you have any instructions for the team of how to balance that a little bit? Because this gets back to that whole thing about fear of transport, fear of a sick baby, and now your baby's or child's being taken away with people that you just met, you know, 10 minutes ago.
Yeah, I think that's a very important question. I think that we deal with that on multiple levels, and there's a balance. There's always a balance. If the mother is a negative pressure room, she's wearing a mask, the transport people are in their full PPE, and the baby is in the isolette with the portals closed. If there's a possibility that the mom can at least see the baby before transport, I think if you can do that, if it's possible, that might be a good thing to do. Again, it takes all the different pieces to be put together to allow that to happen for everybody's safety. But on the other hand, it's extremely important that the mother see the baby. So I would really try and work with the referring facility again to set that up. And it doesn't have to be an hour visit, it can be a glimpse, but a mother that doesn't get to see her baby before transport is devastating. But you don't want to put yourself at risk. So you have to balance it all out.
No, absolutely, absolutely correct. This gets into some of the equipment issues. And Mike, you might be able to answer this one. You know, one of the things we talk about is eye protection and the necessity of eye protection. And what we're noticing though is that whether it be the goggles that were in the presentation or a face shield, folks are getting a lot of trouble with fogging up. And especially now if we're saying that from the time that you begin your clinical care of the patient till the time the transport's over, you have to wear some form of eye protection. Have you had any experience with this, and can you give any kind of insight for folks that are experiencing that problem so they can still maintain that level of protection?
I think this is probably one of the greatest struggles that we have, because the guidance that also comes out from our organizations is not to use tape, not to put anything that's between your face and the mask, which traditionally from a surgical mask standpoint has been our norm. You know, a piece of 1-inch tape does all kinds of fun stuff when you're in the healthcare world, or the classic duct tape approach to this. Right now, I think a lot of people wearing cappers aren't seeing the issues that we're seeing when you have to wear the N95s. You know, so I've got my N95 sitting here because I'm actually on service right now and have gotten into a flow of how to do this. And it's hard in the back of an ambulance to take a break with your mask. But I think the important thing is even before you put your N95 mask on, and if you wear glasses like I do, is take your glasses off so that you get your mask on appropriately, and make sure your face is clean as well as your hands, and that your face is also dry as you put it on in order to get your seal. And I'm sure I'm violating some way of putting my mask on, but I'm going to do it quickly, right? Is to get it on yourself, and then to make sure with the metal clip, you get a good seal, because what happens is the humidity when you exhale, if it comes up, gets on your face shield or it gets on your glasses. And so you got to make sure you got that good fit and that you got a seal with it. And you take a couple of breaths. And what I found with my glasses is that if I get them to actually sit on the mask, not underneath the mask, and on the bar, I get a whole lot less fogging with it. And when you put the face shield over it, it doesn't crush things as much as what it does over time. And so even as I'm breathing here, my office is a little bit dark. I'm fogging up just a little bit, which tells me on one side, I don't have a good seal on my nose. I also didn't clean on my face. We're seeing a lot of pressure points also with people that are wearing their masks all the time. So if you have an opportunity, our guidance is to try to take 5 or 10 minutes away every hour from the bedside, which is difficult in a transport, but to let your face air out a little bit, right? And then it's really about good protection of your skin, good cleaning, and there's a lot of good soap products that are out there in order to help with the oils like that. One trick that I have found with, at least with my glasses, is keeping your glasses clean. Soap and water, not just rubbing them down with your shirt and hoping that that's good enough, because it creates a little bit of an electrostatic barrier in order to help decrease things. And I'm going to take this off because I hate this thing.
Great advice. Great advice. Thank you. I just want to make a shout out to Amy Gould, who's in the room here with me, and she's trying her hardest to get everybody's questions in the queue so that we can get to them. We have about 30 minutes left, so we'll try and get to as many as we can, but you guys have got some wonderful questions coming in, that's for sure. Tom, there's been several questions which have talked about the use of high-flow nasal cannulas, nasal CPAP, and other types of devices with regards to risk of aerosolization. I know that we talked about in the talk about anything greater than 2 liters per minute. Do you want to talk a little bit about that as far as those particular high-risk type of interventions?
Thanks, Rob. Yeah, so aerosolization is the concern. You know, me speaking, I'm producing vapor, I'm producing potentially respiratory particles. Hopefully I'm not spreading COVID. I don't think I am. But that's considered a lot lower risk than aerosolizing. So I'm generating even smaller particles that can last in the air much longer. So the interventions that we do to children and babies that are considered aerosolization is the active intubating, is anything greater than 2-liter flow. So high flow nasal cannula at higher rates of flow, CPAP, NIPPV, intubation, any of these procedures, particularly respiratory procedures, of course nebulization is a big one, is considered higher risk for spreading the virus. And so in those particular patients, we want to use the highest maximal PPE possible. So in our institution, if a patient is on more than 2-liter high flow, then we try to put them in a negative pressure room, and everybody who comes in contact with that patient and enters the room, that is healthcare worker, needs to wear an N95 mask, eye protection, gown, and gloves, of course. And then certainly if you're intubating, you would need at least that protection. We are fortunate we've got enough PAPRs that the person intubating, we feel like, should wear the PAPR and the rest should use N95s. The one other area that doesn't get talked about a lot that is considered aerosolization is the second stage of labor. So if you're standing in the room and a mother's pushing and pushing and pushing, as you can imagine, is generating aerosolized particles and potentially is a higher risk situation for exposure. So we've created a policy here that anybody entering the room during the second stage of labor, if you're PUI or COVID positive, you absolutely have to wear maximal PPE. So for us, it's PAPR, it could be a capper, or N95 mask with eye protection. So that's a lot to say. That I learned a lot in the last 2 months about aerosolization. I'm sure you have too. But that's what we've defined for our patients as aerosolizing procedures.
Thank you, Tom. Thank you. There's a question that came up about the setup with the filter when given PPV, and that could either be through an intratracheal tube or a mask. And in some cases, the setup is such that the manometer is on the side of the mask and not on the side of the patient. In which case then, as you give more pressure to get the patient to move the chest, you're going to be measuring that pressure with the manometer. And so how are you really going to gauge whether you're giving too much pressure to the child? And what the teams have been telling me is that it's turned into a clinical where they've been watching for chest rise and listening for breath sounds. And that's about all they have at this point in time. And again, they notice it more and more as the humidity fills the filter. In the slide that I gave you guys and showed, in that particular slide, the manometer was actually on the side of the bag, and therefore you had the filter and then the patient. So it would run into that same situation, in which case it would make the manometer null and void. So it's unfortunate unless you have a setup that puts a manometer on the side of the patient. But again, you'll have to go with your clinical acumen, and that's the best we can probably recommend. Dr. Harris, I have a question for you.
Yep.
You know, like it or not, whichever view you're on as far as opening this world back up again, too soon, too late, et cetera, it's going to happen. And I think that the consensus among the scientists, we'll leave it at that, is that this bug is around for a while and it's here to stay. And so what do you think from an infectious disease standpoint is the best way to protect ourselves as we move forward and begin to lift restrictions and enter a new respiratory season? Is there a period in time where we can tell transport teams that we don't think they need to wear eye protection and N95s or surgical masks and gloves and so forth?
I think it's a new normal. I think that we probably are not, from a medical standpoint, a transport standpoint, going to be able to lessen the amount of PPE that you do use. I think that that's the new normal, and particularly with this reopening, you all are also going to be potentially going to a restaurant or getting your hair cut, maybe even a tattoo, but that's going to be putting you more out into the community and also exposed to COVID-19. Again, I would caution a few things. If you are at risk, over 60, underlying diseases, to be quite careful how you reopen your personal life as related to what you're doing professionally. I think professionally, the PPE that we're talking about today will stay in place. And I want to make a couple comments about the testing. The testing is very difficult to interpret, as I mentioned before. This is a very sensitive test. If a positive is a positive, it's the negatives that we're having trouble with. And I had mentioned before that you can be negative before you even show symptoms and then turn positive, and we've had babies do that for us. And so the better part of valor is to assume that that baby is positive or could be positive. Now, respiratory season comes along with RSV and influenza, and it all gets even murkier about what is this? It's flu positive, COVID negative, but maybe there's a screening risk involved in the household. It becomes very confusing. So I would suggest to you that you continue to protect yourselves, and that any release of restrictions on PPE is probably not going to happen unless there's a PPE shortage, and then you will go to contingency plans that will be directed by your area, your company, your hospital. You need to be aware of what's going on in your area. So I think that it's very tricky, and there's no pat answer. And I think the other thing is about aerosolization that Dr. Lancaster talked about. I just want to direct you to a study from a choir that was in a closed environment. There was an asymptomatic positive, and singing actually has more aerosolization. So you go from talking to yelling to singing, and the majority of people in that choir practice, even though they were doing social distance and, you know, doing all the right things, they were in an enclosed space. So it's the viral load plus time is the risk for infection. So the jogger running by you outside is not going to be the person that's giving you COVID. It's an enclosed environment, and I would suggest that an ambulance, a helicopter, the airplanes are closed environments. So I would take the maximum precautions you can, even if other restrictions are lifted.
Thank you, Dr. Harris. Dr. Meyer, a lot of questions we've been receiving in regards to ambulance and cleaning of the ambulance, how we deal with equipment that might be in closed compartments, and then specific types of agents using like hydrogen peroxide and so forth. What do you know as far as, what do you guys do as far as your ambulance cleaning? Does your team down there have a set protocol that they follow with Environmental Protection Agency approved agents?
We do, and I'm actually, as I look down on my phone right now, I'm actually trying to pull it up if I can find it. We use, everybody's a little bit different. Some places own their own ambulance, other ones are dependent upon vendor from an agreement standpoint. And as we went into COVID, we are vendor run ambulance service, as well as our helicopter as well, that we sat down and they were actually out in front of us in what guidelines that they are going to use. And so I'm looking, they use a combination of a hydrogen peroxide containing, and they also have an autoclave system for the entire ambulance that exceeds CDC guidance. And it just takes your rig out of service for a longer period of time when they do it. It also includes, when they spray down the ambulance, is 20 minutes of contact time for the solution that they use, with all of the fans running. And then after the 20 minutes, they open the ambulance back up and then wipe down any remaining liquids as they go through that process. And that's very similar to the helicopter that we utilize as well.
Thank you, Mike. And I'm sure they're probably, they're telling you, they probably tell you they're in full gear when they're doing all this cleaning as well.
Absolutely so. They probably are in a deeper decontamination outfit than what we're wearing for enhanced isolation.
Tom, a question came up, which, you know, I think is very good. It talks about getting referrals from facilities that don't have the luxury of having a rapid COVID-19 test available to them. And they go to pick up a neonate that, say, for instance, the mother had a fever. And I know Dr. Harris has mentioned this before, that don't forget, just because COVID-19 is here doesn't mean you still have RSV and endometritis and chorioamnitis, et cetera. So in this situation, though, where you do get the report that mom has a fever and they can't do testing on her, how do you feel the team should respond to this in this massive unknown situation, as far as taking it all the way to positivity or treating it in caution, and keeping in mind what we have as far as limitations with PPE in many areas?
Yeah, that's not an not an uncommon situation. It's, especially in the beginning, that's exactly the scenarios we lived out. We didn't have rapid testing. In fact, it took a week for one of our first PUIs to come back. The short answer is I would treat her as a PUI until proven otherwise. Fever is one of the most common symptoms of COVID, along with dry cough and so forth. But you're right. You have to consider many other diagnoses, and probably more likely would be something like chorioamnionitis. But I would treat that mother as a PUI, and therefore the baby as a PUI, and I would respond with the appropriate PPE for that situation. In which case, I personally would put on a PAPR or an N95 to interact with that mother, of course, eye protection, so forth. But I'm hopeful that as testing becomes more and more widespread over the ensuing months, especially with the availability of the rapid testing, that we can apply the necessary treatment algorithms appropriately. I think from a PPE standpoint, take the maximal protection. I think as far as how do you manage the mother and the child, that's where I think testing is going to be helpful. It may rule out COVID, but rule in potentially chorio if you have a negative test. But again, what Joanne was talking about earlier, I agree 100% that how good is the negative test? It's only as good as the sample that's drawn and the time during which it was taken for that illness. So the negative is the really difficult to deal with. A negative test doesn't 100% rule out COVID. So I would take the most conservative approach, especially if a person's symptomatic.
Absolutely, absolutely. Thank you, Tom. Dr. Harris, Joanne, this is a really interesting question. I don't know who asked this, but this is a great question, guys. Is there specific pediatric literature on the infectivity of aerosolized secretions for other viruses that might be parallel to what we're experiencing with COVID? Specifically, they're looking to see the ability to communicate disease from a neonate versus an infant versus an older pediatric patient versus, say, a teenager. And do we think that one population may be less able to communicate the disease to another?
That's a great question. It's under investigation, as they say. They know from an adult population and experiments how many particles come out, surrogate particles come out at regular, as I talked about before, breathing, yelling, talking, singing. They have done a lot of estimation about how many particles are released over what period of time, and therefore how infectious they'll be. You know, one of the big questions is the neonate and the young child, because we know as pediatricians that they don't cough like an adult. Those children swallow their secretions, and that's why children with tuberculosis don't transmit TB. But we don't know for sure about how much virus is being expelled, right, from the child, even with the aerosolizing procedures, and how long you have to be in contact with that child for that dose to actually be infectious. So it's the great unknown right now. There is literature out there for other diseases. We know flu very well, RSV, but COVID is not necessarily the same situation as you're now hearing. COVID is not the flu. And so it's a wonderful question, and people are definitely looking at that. There is more knowledge about the adults, and you know, every day I think, how much really can a neonate spread, really? But in fact, we don't know, and therefore you have to take the maximum precautions until some of that information comes out. The disadvantage, huge disadvantage we have with COVID-19 is we don't have any previous knowledge. We've known the flu for 100 years. We know a lot about the flu, but we don't have that knowledge, as every day there's a new symptom. Many pregnant women that test positive do not have fever. So testing for fever may not be the way to identify a COVID positive mother, but she has some diarrhea. Well, when you're in labor, you might have diarrhea. So it's all the great unknown. And I go back to my premise, which is a personal one, is we can't do anything without you guys keeping yourselves healthy. And so that's the approach. I understand there's contingency when there's PPE problems, but I think hopefully we'll be getting more and more PPE available. Let's keep our fingers crossed.
No, absolutely correct. Absolutely correct. Dr. Meyer, Mike, I know we talked a little bit about the use of PAPRs and capers, and for folks that can't wear N95 masks on the helicopter. I guess for further clarification, and I'm not aware of any significant EMI that would be transmitted out of a PAPRs or CAPRs device. Are you aware of any EMI or anything that would preclude the ability for a team to wear a PAPRs or CAPRs on the helicopter if they did not or they failed the N95 fit test?
Nothing that I'm aware of from an EMI standpoint. There was one question that popped up that I'd like to just comment on quickly, because it was about what is really the ideal combination of PPE for long-term transports. Because unfortunately, that's the reality of what we do many times. And this is where I go back to my military experience. And when you're told to put your gas mask on and you're told to put on your chem gear, and you take it off when you're told it's safe to take it off. And it's, as unfortunate as I hate to say this, this is part of the job, and that we signed up for in order to do it. And that's a hard message, because everyone who goes out in these circumstances is in an unknown risk factor, but we believe that the risk is greater than our baseline when we're transporting a child. And we accept more risk just for being in a moving vehicle in order to provide critical care to a child or a neonate. And this just adds to that, both in terms of anxiety, distress, as well as the fog of the transport and the physical distressors that you go through. Don't short circuit your safety for convenience and sweating less. Nomex is a great material. It allows you to sweat and you get to keep it. And it's a lot of fun. And you may have to change your uniform multiple times and have a process in order to do that. These are all things that we have to think through for the safety and then the convenience of our transport teams. Because if we lose our transport teams, many of our patients lose the ability for the higher level of care that they truly need. So don't short circuit your needs.
No, very, very well said. Very well said. That's for sure. And folks, another example of that is one of the reasons that we make the recommendation to take the gown off, especially when you're on the helipad or the flight pad, is as Mike had alluded to, the Nomex is meant to buy you some extra time in a fire situation. If you're wearing a gown over that Nomex, you just basically put some kindling onto your little fire post. And so that will burn up quite quickly. So those are one of the reasons we look at the risk-benefit ratio of what we do. From the standpoint of the PAPers and the CAPers, I would just add that anytime you feel uncomfortable that maybe there might be something there that might affect the flight, you need to discuss this with the pilot up front and before you leave. This is very, very important. I guarantee you that pilot is going to be extra vigilant when they talk to you, but their interest is to make sure that you fly as safely as you possibly can. And in this particular case, the safety of you and the PAPers may be the answer that needs to happen. I think with the neonates, we feel a little better because they're in the isolette, and when they get inside the ALSS, we feel that they are in their isolation room. There's been a lot of questions coming up in regards to whether that's enough to prevent any exhalation of viruses and so forth out of the ALSS. Those questions and some of the questions that relate to equipment, I'm going to steer you to sending emails and getting in contact with the great folks at International Biomedical, and they can certainly counsel you on that a lot more. As far as there was a question that came up, Mike, in regards to the distinction between HEPA filters use for a small neonate and a large patient. Do you guys use any type of HEPA filter when you do your pediatric versus your neonatal transports or not?
No, we use the exact same filters. And I think it goes back to your comments about understanding the clinical things that you're seeing in the care of those patients. The closer you have things to the patient, the less you have to worry about dead space and things like that. But all of this is some type of calculated risk. And what you want to try to do is to minimize the amount of aerosolization that is occurring in the environment around you, because we are all in a small box, whether you're in a helicopter, a plane, or an ambulance. And so having some type of filtering. And if you run out of HEPA filters, there's a couple of filters out there that sometimes you got to put 2 filters on in order to get up towards what a HEPA filter provides for you. And you have to assume every patient is positive. Here in Milwaukee, we are now testing every patient that is admitted to the hospital. Doesn't matter what their symptomatology is, and we're trying to put them into either a surveillance or a PUI status as we move forward. But our penetration of COVID in our community is relatively low, and it allows you to do things like that. But if your community penetration is high, for example, in New York, where you were seeing 20+% positivity in your testing, it's really hard to distinguish high risk or low risk because everybody's high risk at that point. But in Milwaukee, we're somewhere around 4.5 or 5%. And it really allows you some flexibility, and everybody's in N95s in the hospital. So we're not worried about inadvertent contamination of the area because we're all in face shields, masks, gowns, and gloves for every patient encounter. And if they are a PUI, we go into capper at that point. And we have all negative pressure rooms on the inpatient side of the house.
Awesome. Thank you, Dr. Meyer. Definitely appreciate that insight. I did get word from International Biomedical that they're compiling an equipment-related questions. They will post an FAQ format on their website. So a lot of your folks who are asking questions about equipment, we will get those addressed, and I'll refer you to the website. And hopefully in the near future, they'll have those FAQs out there. Tom,
Rob?
question. Oh, go ahead. Yeah, go ahead.
Can I just reiterate a little bit about what Dr. Myers is saying?
Yeah.
Not all hospitals are testing all admissions, and not all hospitals are wearing N95s and face shields for all inpatients. Part of it is contingency for the amount of PPE they're wearing. And so you will come across different policies in different hospitals, and you should be aware of that. It's actually the minority that are testing everyone as inpatients. Right now, mostly they're testing elective surgeries and the pregnant woman in a lot of the facilities. And again, I caution you that the negative test does not give you great confidence if the patient otherwise, or the household, if it's a young infant, has symptomatology. So your screening procedures are absolutely key, and that I would caution you to know your referring hospital. Find out what's going on, what they do, and just keep in the back of your head that you're transporting this child and what you need to do to protect yourself, as well as obviously take good care of the baby or child. So it's a balancing act. So the testing itself is a bit of a problem, and certainly if some hospitals have gone on to do serologic testing, if that is the case, serologic tests do not identify infectious COVID patients. So if they're using serologic testing, take that into account. So unfortunately or fortunately, you all are going to become really good experts on asking questions and understanding testing. So I would, if you're a bit confused like I am all the time, I would try and educate yourself on the pros and cons of the testing in light of what you need to do for the child and yourself.
Well, Rob, let me add to that real quick. I think what Dr. Harris really said, and what's really important, is that the level of the transport team, you have to understand your policies and your best practices and not compromise on that, remembering you're bringing all of the equipment that you need to meet those standards with you. So if you can do that based on your supply chain, then that's what you should be doing. And if you walk in and they're like, well, no, we don't think this patient's a PUI, but in our input to our center is, no, we call this a PUI, treat that patient like a PUI, but explain to the family and the staff why you're doing that. You know, so that good lanes of communication, because a lot of this is based on our experiences, because right now we're in the information gathering phase of what COVID-19 really is. We don't have a good understanding. So be safe, protect yourself. Healthcare workers represent between 10 and 15% of all of the people that have been infected with COVID-19 from what has been tested. So we are the most at risk. It's been shown that we are the most at risk. So protect yourselves.
Absolutely correct. And, you know, a lot of the dedicated teams, you know, their numbers may only be anywhere from, 12 to 30 people to support the number that they do. And if you end up taking 10% or 20% of those folks out of the picture because of COVID-19, think about how that cripples your ability to do effective transport. Tom, there's a question that came up, in neonates, we use uncuffed endotracheal tubes. And so how do we respond to a situation whereby we have to intubate a child and now they're on a ventilator and we're going to take them into the back of our ambulance or in the back of the helicopter and so forth? Do you have any thoughts in regards to aerosolization in that particular situation, knowing that we're using an uncuffed tube and there may be air leak?
Yeah, the fact that the child's on positive pressure alone is an aerosolizing procedure. So it's, I assume we're talking about a COVID positive or a PUI. I would consider that aerosolizing, regardless of cuffed or uncuffed.
No, I agree. I agree. Another question for you, Tom. What about as far as folks walking through the hospital? It's one thing to go to the clinical area beforehand, but now you've got your patient, could be a pediatric patient, et cetera. What about as far as the PPE and walking through the hospital and stuff like that? Do you think they should continue with the full PPE all the way out?
I would if you're with the patient, absolutely. I mean, your highest risk of exposure isn't me walking past you and you have PPE on and I don't. As Joanne was saying earlier, it's your contact with that patient. So I'd continue that PPE precaution as you're exiting the hospital with the patient.
Absolutely, absolutely. Okay, I think we're pretty much getting towards the end here. There is a question here. I'm going to shoot this over to Dr. Harris. It regards the storage of the N95 mask. And folks were wondering as far as the recommended storage, should it be paper for paper mask versus plastic and so forth, and what you recommend for the N95 during transports and in between transports.
So it depends on whether you're talking about a used N95 or an unused N95. Various institutions have various ways of reutilizing N95s in a contingency situation. So there is that you wear the N95 during the entire shift, for example, and then you turn the N95 in and you'll get another one. Then there's others that keep track on the mask that, 5 uses, for example. There's others that have enough N95s that, you can change in between patients. So it's very, very variable. The thing about storing an N95 is to make sure you don't fold it, because that inactivates, the effects of it. And, the outside surface of the N95, just like Dr. Myers was wearing, that's the, quote, contaminated part. An N95 is to keep you protected from incoming virus. The regular level 1 surgical mask is to prevent you from giving the virus. So you do have to be careful how you touch the mask, as Dr. Myers was speaking about, and how you store it. Some people store them in plastic bags with their names on it. Some people store them in paper bags. To reuse the N95s, they're utilizing paper bags to store the masks. So I would refer to your home facility as to whether how they're reusing their masks, are they sanitizing the masks, and how they want you to turn in the mask if that's something to be sanitized either by hydrogen peroxide or UV light. But remember, when you're handling the mask, don't fold it, and be careful about touching the outside of the mask. There are other facilities that give people 5 masks, 1 for each day, and by the time you come around to the beginning, the mask has been there for 5 days, and assuming that the virus has not lived that long. All kinds of contingency plans. So I would make sure you know what your home institution is doing and follow the recommendations.
Definitely sound advice. Sound advice. There's a question that came up here about requiring continuous albuterol. Is that too considered aerosolizing? And the answer for that would be yes. There was a question that came up about hospitals seeing a decline in transport volume. We did see a little bit of a decline in our neonatal transports. I worry that it may be that folks have gone to some home birth, but hopefully that's not the case as far as COVID-19. I will say, as far as our unit is concerned, we have not seen a decline in our census. Dr. Meyer, this is might be the last question we have time for, but it certainly is appropriate given the announcements that were made today. Want to know what you make of the Kawasaki-like illnesses that we're seeing, the inflammatory response illnesses that children are having during relationship to COVID-19. and the concern that this may be yet another manifestation of the COVID-19, just like the thrombosis in the adult patients.
You know, it's actually good timing for that kind of question. And we're starting to see additional guidance that's coming out, especially from New York. Today, we had a group that met and started working on what our policy guidelines are going to be for this type of patient, a standardization of our consult process, as well as identifying imaging needs for patients. When the debate has been whether or not these patients are PUI status or not, because it's been quite a mixed bag of, are they positive, are they negative, are they positive now? But you know, we're hearing about the whole gamut of these. We have multiple viruses in the pediatric world that we see post-viral inflammatory syndromes. And so I don't think any of us should be surprised that COVID has a post-viral inflammatory process that may be associated with it. We are in the same boat that we were in 2 or 3 summers ago when we were looking at enterovirus and the acute flaccid myelitis, that we finally narrowed down to some D86 bug or something like that. I'm sure that Dr. Harris would have all of the details at the genetic level of this virus. And so it's not surprising, but it's extremely distressing, because the literature out there and everything that we see is children are not as affected by COVID-19. They are just as infected, and they are probably just as much of asymptomatic carriers, if not a little bit more than adults. But this may be a consequence of a delayed inflammatory, delayed immunity response. Right now, it looks like that it's seen predominantly in areas based on the COVID-19 infectivity rate in the adults and what the background in the community is. But that's what I would say today. And I would tell you tomorrow, we may know something different, but this has to be part of your differential, right? And I still go back to protect yourselves, think about worst case scenario, and don't let someone poo-poo that, oh yeah, don't worry, this patient doesn't have it. Because I've had plenty of emergency departments tell me this patient has to have it. They have all of the symptoms, it has to be it. And I'm like, but yeah, those are the same things as influenza and RSV, and they're more likely to have influenza and RSV. So we shouldn't belittle it, and we also shouldn't let people explode because of the drama about it, that we should treat all the patients in the same fashion, which is a great example of the way we should practice healthcare anyway.
Well, thank you, Dr. Meyer, and thank you, Dr. Lancaster and Dr. Harris. This has been a wonderful discussion, and we've had some very incredible, well thought out questions from all of our attendees. Thank you so much for those questions. Certainly in the future, going to International Biomed's website, there'll be an FAQ there, and I'm sure if there was additional questions that you need help with, they can get in contact with me, and any one of the 4 of us can get back in contact with you. Because as I said at the beginning, you know, transport's a team effort, and the experts are not only the ones that you see in front of you, but all of those folks that were attending this website. We all are in it together, and we all have something to give, and we all can learn from each other. There will be a program evaluation which will be sent out to you by email. Your colleagues that again could not attend can pick up on the recorded version that will be on the International Biomedical website. We encourage now everyone to stay behind. There's a short video here that's been put on by the folks of International Biomedical. Again, I really want to appreciate them for allowing us to put this on. I think the format has been very educational for folks. And last but not least, folks, please stay safe out there.
All right. We're going to miss you at the conference this year, but we're still here for you.
this stuff does. But I know who the real heroes are, that's you healthcare workers out there. Thank you for all you do.
Can't wait to see y'all back in Texas next year. We'll be ready to party with you then.